This is PediaCast.
Welcome to PediaCast, a pediatric podcast for parents. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast. It is a pediatric podcast for moms and dads. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 542 for August 15th, 2023. We're calling this one Turner Syndrome. I want to welcome all of you to the program. So this week we are covering a genetic condition known as Turner Syndrome. And it's a condition that is fairly common compared to other conditions we cover on PediaCast, affecting about 1 in every 2,500 girls in the United States. And yes, I said girls because Turner Syndrome overwhelmingly affects females compared to males. And it's caused by a missing or partially missing X chromosome, which is one of 2 sex chromosomes our body has in every cell. Now, fortunately, girls have 2 copies of the X chromosome, one from mom and one from dad. So if one of them is missing or partially missing, they still have a working X chromosome. Boys, on the other hand, only have 1 X chromosome. So if that 1 X chromosome is missing or partially missing, then there is no backup, which is not compatible with life. Now, despite having 1 fully functioning X chromosome, there are still lots of potential consequences that can impact females with Turner Syndrome. And today we're going to explore these consequences. We'll uncover the cause of Turner Syndrome and explore its signs and symptoms, diagnosis, management, complications. We'll also cover the long-term outlook for those with the condition and take a peek at the latest research findings related to Turner Syndrome. Of course, in our usual PediaCast fashion, we have a couple of terrific guests joining us for the discussion. Dr. Jennifer Ladd is a pediatric endocrinologist at Nationwide Children's Hospital, and Dr. Chelsea Kebodeaux is a pediatric and adolescent gynecologist at Nationwide Children's. Before we get to them, let's cover our usual reminders. Don't forget you can find PediaCast wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you get your podcasts so that others who come along looking for evidence-based child health and parenting information will know what to expect. We're also on social media, and we love connecting with you there. You'll find us on Facebook, Twitter, Threads, and LinkedIn. Simply search for PediaCast. We also have that handy contact link over at PediaCast.org if you would like to suggest a future topic for the program. I want to remind you the information presented in our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. If you have a concern about your child's health, be sure to call your healthcare provider. Also, your use of this audio program is subject to the PediaCast Terms of Use Agreement, which you can find at PediaCast.org. So let's take a quick break. We'll get our expert guests settled into the studio, and then we will be back to explore Turner Syndrome. It's coming up right after this. Dr. Jennifer Ladd is a pediatric endocrinologist at Nationwide Children's Hospital and an assistant professor of pediatrics at The Ohio State University College of Medicine. Dr. Chelsea Kebodeaux is a pediatric and adolescent gynecologist at Nationwide Children's and an assistant professor of obstetrics and gynecology at Ohio State. Both have a passion for managing and supporting children, teenagers, and families impacted by Turner syndrome. That's what they're here to talk about today, Turner syndrome, along with its cause, symptoms, diagnosis, treatment, and complications. But before we embark on that conversation, let's give a warm PediaCast welcome to our guests, Dr. Jennifer Ladd and Dr. Chelsea Kebodeaux. Thank you both for stopping by and sharing your expertise with us.
Thanks so much for having us.
Yes, we're excited to be here today. Thanks for having us.
Yeah, really happy to have you guys here. This is one of those topics I think that all of us learn about in medical school. And unless you see it all the time, a lot of times it's not one of the first things that comes to our mind. So I want to just start with a reminder, just a brief definition. Jennifer, what exactly is Turner syndrome?
Sure. So Turner syndrome is one of the most common sex chromosome abnormalities that we see in those who are assigned female at birth. So typically, and what we learn about in medical school is what we call classic Turner syndrome, where girls with Turner syndrome have only one copy of the X chromosome instead of two. However, in real life, there are lots and lots of variations to this, where some girls have part of an X chromosome in addition to a full X chromosome, or different structures of the X chromosome, or even where some cells might have two X chromosomes and some might only have one, something called mosaicism. So all to say is, as with a lot of things in med school, it's not quite as straightforward as we learned.
Yeah, absolutely. So just to kind of sum that up, because we have lots of learners at different various levels within pediatric medicine. So as we think about the chromosomes, XX is a girl, XY is a biological boy, and or maybe I should say male and female. What happens is that the females with Turner syndrome have one normal X chromosome and then one that is either absent or missing parts of it or is somehow abnormal. And that's why we have such a great degree of how it's expressed, depending on how much of that X chromosome is there. Is that correct?
Yes, that's a fair summary.
So we don't see it in boys because they only have one X chromosome to begin with, and if there's significant anomalies with that chromosome, it's sort of incompatible with life, correct? Yes, no, am I completely off base?
No, potentially. I would say we're learning that there are a lot of variations. So there are individuals that could be mosaic 45X, so have some cells with one copy of an X chromosome, and then the other cells might actually have a Y chromosome or an X and a Y chromosome. These are kind of differences of sexual development, probably a little bit outside of what we're talking about today, but all to say is kind of the sex and the chromosomes that we're born with are certainly different than the gender that might be expressed by the child growing up. But in general, what we are talking about today is those that would be born female with two X chromosomes, and for whatever reason, one of those chromosomes is either missing or not formed completely correct.
And so it's really more complicated than what we learned in medical school, where Turner syndrome is X0. There really is lots of ways that this can be expressed, and we don't expect everyone who's listening today to become experts at Turner syndrome. That's what you guys are for. But I think it is good to sort of have that background that this is not necessarily as straightforward as we have learned. So then, Chelsea, how common is Turner syndrome in practice?
So it's recorded as about one girl in about 2,000 to 3,000 live females at birth. But we think it's actually more common in pregnancy because a lot of pregnancies with genetics consistent with Turner syndrome actually don't survive to delivery. And so when someone has a miscarriage and they look at the genetics of what may have caused the miscarriage, Turner syndrome is found about 10% of the time.
So it's actually, I would say, probably more common than many of us would think. One in every about 2,500 live births. I mean, that's in line with a lot of the other diseases that we talk about on a pretty regular basis that we probably know more about. I suspect that there could even be folks with Turner syndrome that go undiagnosed maybe their entire life. And so, that may make the numbers a little higher as well.
Exactly. So we think that might be an underestimation because there's a difference in phenotype, is sort of the medical word, but a lot of variation in how girls and women may present. And so there may be women who have Turner syndrome who are just never diagnosed with it.
Yeah, absolutely. So then who is affected by this? Are there risk factors, or is this completely a random chromosome problem that occurs really at conception or, very early on in development?
Yeah, we think it's a random difference. So there's no family history factors that have been associated with developing Turner syndrome. Like some other chromosomal differences, maybe the age of mom or other things may affect the risk, but we don't see that with Turner syndrome. And so we don't expect families who have a child with Turner syndrome to have a higher chance of having a sibling with Turner syndrome or something like that.
Yeah, so that's really interesting. So it's a genetic disorder, but not necessarily one that's passed from generation to generation. It's just something goes wrong with the X chromosome early on in development, and we don't really know exactly what that is. We can't really point to like it was alcohol or smoking during pregnancy, which both of those things are not healthy and not advised for sure. But we don't know that that's what causes Turner syndrome. Okay.
Yeah, and I think that's a pretty important point. That this isn't something that the mother or the parents did do or didn't do. This is something that just happens during pregnancy and just happens to affect the child. So this isn't something that could have necessarily been preventable in some way. I think families feel a lot of guilt sometimes.
Yeah, absolutely. I think that's a really important point that it's not something you did. It just happens. And the more, with any of these kind of diseases, the more that we know and understand and can improve health literacy for people, the easier it is from a mental health standpoint, I think, to deal with what you've been dealt. So what are some of the signs and symptoms then associated with Turner syndrome, Jennifer?
Yeah, so I think like we've kind of talked about already, Turner syndrome can be very subtle, and the symptoms and the features that every girl can have can be different. So I think, when we think about what we learned in medical school and kind of the classic presentation of a girl with Turner syndrome, we think about someone who is shorter in height, someone who might have a broader neck, something we call a web neck in medical parlance, but also a lower set hairline, kind of wider space nipples, sometimes swelling of the hands and the feet. But oftentimes girls don't have all of these features and might only have one. So it makes it very challenging to diagnose. And like Chelsea was saying, potentially we are underdiagnosing these girls, and we do sometimes end up diagnosing girls at an older age when they present with some less typical features.
Is the slowed growth pretty universal, or is that also variable?
Yeah, that's a great question. I think, we think about short stature as being one of the hallmark features of girls with Turner syndrome. So certainly if a girl is growing below the third percentile, which is our kind of endocrine cutoff for short stature, thinking about Turner syndrome as something we do. Or if the girl is growing much below where we might expect them to be based on how tall mom and dad are, that's another reason that we might suspect Turner syndrome. However, as I say this, I also follow some girls who are nowhere near the third percentile and are actually growing very well. That's a bit more common in girls that have this mosaic Turner syndrome, where some cells only have one X chromosome and some cells have two. But again, all to say with the theme of today that there is a wide variation in how patients with Turner syndrome can present to us.
Yeah. So short stature, less than the third percentile, is one of those things that should at least raise a little bit of a red flag that maybe we should pursue this a bit more. What about delayed onset of puberty? Is that something that during the adolescent years, may also raise a red flag for this.
Yes, and I think both of us can speak to that, but certainly from an endocrine perspective, we consider puberty delayed if a girl doesn't have any features of puberty, so any breast development, pubic hair, periods by the age of 13, or if they've had some development of breasts but don't have periods at all by the time they're 15. This is something that we would think about, or if they've started puberty, had periods, and then all of a sudden stop having them, this could potentially be something that we think about as well.
Yeah. So you may you may have delayed onset of puberty, but you could also have sort of normalish onset of puberty, but then it sort of stalls and doesn't progress like you would expect it to. And for the parents out there listening, I would say this is even another reason why it's really important to see your pediatrician every year and to kind of see where you are in the growth chart, see how puberty is progressing and all of those things to really pick up on this. And we'll talk about this more later, but it is important to pick it up because there are specific complications to kind of watch out for. Some of those involve the heart and the kidney. So heart and kidney issues can also, like if you see those, may also be a red flag, right?
Yes. Turner syndrome can affect kind of a variety of organ systems. So, as an endocrinologist, I'm partial to thinking about the endocrine organs, so things like thyroid disorders or diabetes, but certainly other organs can be affected as well. So girls with Turner syndrome are at higher risk for having certain heart malformations, such as a bicuspid aortic valve, which basically means they have 2 flaps in the aortic valve instead of 3, and also problems with aortic dilation, so the aorta getting bigger, or potentially problems with how the kidneys form. So whenever we diagnose a girl with Turner syndrome, we always do a screening ultrasound of the kidneys as well as the heart, something called an echocardiogram.
So Chelsea, I want to pull you in with Turner syndrome. Some of these signs and symptoms that we're talking about with short stature and delayed onset of puberty, perhaps heart and kidney issues. There's really a wide range of things that can cause these problems. What are some of the more common ones that maybe the explanation is not Turner syndrome, but something different?
Yeah, so delayed puberty or never starting your periods or stopping your periods after you've started them is the main way I'm going to end up diagnosing Turner syndrome as a gynecologist, because I may have a pediatrician refer a patient to me for the evaluation of that. And there are a wide variety of things that can cause delayed puberty or not starting periods, including something as simple as constitutional delay. Maybe everyone in your family didn't start puberty until they were 16 years old, and that's just sort of part of your family history. Although we kind of use that as a diagnosis of exclusion, meaning we need to rule out all these other things before we'd say that that's the most likely cause. If your child is very low weight or has a lot of chronic medical conditions, that can sometimes delay puberty development. Basically, we explain that as sort of a low energy state where maybe the body is not putting as much of its energy, towards the reproductive system. You could have differences in development of the uterus or vagina, the reproductive tract, where maybe you have started periods, but the periods aren't able to come out because there's a blockage, or you were born without a uterus, which can sometimes happen. Other causes of the ovaries not developing, maybe there is a differences in sexual development where you have different sex chromosomes than we'd expect based on your phenotype or your determination as female or male, as well as thyroid disease like Jen mentioned, and then potentially your ovaries not having the function that we expect, or primary ovarian insufficiency, which is a common diagnosis within Turner syndrome. You may have autoimmune disorders or Fragile X, or a lot of times the cause of that is idiopathic if we don't find out anything else.
So with all of these other things that could potentially cause the clinical scenario that we're seeing, how do you then settle on Turner syndrome as a diagnosis? Like, what's the definitive thing you would do to figure out that this is what's going on?
Yeah, the definitive test is actually quite easy. It's a blood test called a karyotype. where they look at several cells, usually at least 30 cells in the body, and look at the number and type of chromosomes that those cells contain. And that's how we diagnose that girl Turner's has 45X or 45 chromosomes with one X, when the typical female may be 46XX. Or some of the variations that Jen was mentioning earlier.
And because of the issue of mosaicism, it is you really do need to look at more than just a little handful of cells, because if they do have mosaic Turner syndrome, and you sample cells that are normal, there may be other cells that aren't normal, correct?
Correct. And we're actually diagnosing Turner syndrome a little bit more commonly in pregnancy than we used to because of a test called cell-free fetal DNA, where the woman, while she's pregnant, has blood drawn and they're able to separate out DNA from the fetus from the mom's DNA. And sometimes that gives us a suspicion that this may be going on.
Yeah. And that is, so that's really interesting. So that assumes that some of the baby's blood crosses the placenta, goes into mom's bloodstream. And so when you're taking a blood sample, you're pulling out blood cells that are mom's and the baby's. Right. And then I'm sure that there's some way to figure out the difference between those two, maybe with fetal antigens on the outside or red cells. I don't know. I'm making that up. But there are ways that you would maybe be able to tell the difference between the two. And that is a lot safer than the alternatives there used to be, like an amniocentesis, where you take fluid that's surrounding the baby, which has risks associated with it, or chorionic villus sampling. Again, those are more invasive ways. So it's really cool that there's a way to differentiate baby's blood from mom's blood and be able to diagnose that.
Yeah, they're more invasive. They are a little bit more accurate, though. So often a family doesn't decide that they want to do a CVS chorionic villus sampling or amniocentesis during pregnancy. And even if they do that, we still confirm the baby's karyotype after birth.
Yeah. And since you mentioned heart and kidney issues, is sometimes that picked up on a prenatal ultrasound, and then that makes you start thinking, could there be Turner syndrome associated with those defects?
It can be, and there are actually some other ultrasound signs, like a thickened nuchal translucency or sort of more fluid around the neck, and some other ultrasound signs that can be associated with Turner syndrome.
Very interesting. And so let's say that we then have a child, whether it's a baby, a fetus, a newborn, or an older child, or even a teenager. Once we arrive at that diagnosis with the karyotype, then Jennifer, how do we go about managing Turner syndrome?
So management of Turner syndrome is really directed at the symptoms or the conditions that the girl has that is associated with Turner syndrome. So there's not a cure per se for Turner syndrome. We don't yet have a way that we can replace that X chromosome into the cells that are missing it, but we are able to manage and treat any associated conditions. So for example, in endocrinology, if a girl is on the shorter side or is not growing as quickly as we would expect, we can augment the growth rate with growth hormone therapy. If a girl develops hypothyroidism, so a condition where the thyroid isn't working as well, we can give thyroid hormone to replace it. So that's kind of the nice thing about what we do in endocrinology, and also for Turner syndrome, is that if a hormone is missing, we can replace it. And the same goes for other conditions that are associated with that. So we can actually induce puberty and periods by giving a girl estrogen and then eventually progesterone replacement. Any cardiac issues will be followed by the cardiologist. Same with any kidney issues are followed by the nephrologists or the kidney doctors. And then some other symptoms or conditions that can sometimes be associated are hearing difficulties or recurrent ear infections that we didn't mention before. And so that's where our colleagues in audiology and ENT can be helpful. And same with any types of learning challenges that these girls may have, or mental health disorders like anxiety and depression that we know are getting more common in the population as a whole. We can engage our psychology and psychiatry colleagues to help as well.
Yeah, and I think that's really an important thing. Those of us who practice primary care type pediatrics, we hear Turner syndrome, we think, heart issues, kidney issues. We want to make sure that they're growing. We want to get them through puberty. But that mental health aspect of it, this is now a girl who's different than other girls. And maybe she didn't understand what those differences were until we arrive at this diagnosis. And of course, there can be bullying. And there's, I would imagine the potential for anxiety and depression. And we don't want to ignore those things either. And so it doesn't necessarily mean they need medicine for it, but even just counseling and therapy and help kids develop tools to deal with all of the external and internal stresses that are going on in their life. We can't stress the importance of that and how that really relates to physical health as well. And so a really important thing to consider. And then I would imagine that the transition of care from pediatric care to adult medicine, as kids are getting older, that's also part of the management of this, correct?
Correct. So just like with any chronic condition, we want to make sure we're preparing our pediatric patients for a transition to the adult world. So learning their health concerns, learning their medications, learning how to navigate this very complex healthcare system. And so part of this, as girls get older, will be preparing them for transition to the adult world.
Yeah, absolutely. And if you're interested in learning more about transitioning pediatric patients to adult healthcare, PediaCast CME episode number 25, I'll just put a plug in because that was a really fun one to do. And I learned a lot from that one. The CME has expired, but the information is still still pertinent. And so I'll put a link to that in the show notes over at PediaCastCME.org. In terms of long-term consequences of Turner syndrome, Chelsea, so we've talked about delayed onset of puberty, maybe stalling of puberty. Does that mean that then there's also could potentially be issues with fertility? I mean, can women with Turner syndrome have babies?
So overall, we always emphasize that we expect women with Turner syndrome to have long, healthy, full lives, especially if they're engaging with medical care, making sure their thyroid and heart are healthy. But infertility is certainly one of the bigger quality of life issues for women with Turner syndrome. So because of the way the chromosomes women with Turner syndrome were born with, they're very likely to have what we call primary ovarian insufficiency. It used to be called primary ovarian failure, and sometimes it's called premature menopause. And essentially what that means is the eggs that form in the ovaries that both produce eggs to have the potential for pregnancy and also produce a lot of the hormones that women have from the time of puberty through the time of menopause are not working or not there. And so this does result in a very low chance for most women, especially with no mosaicism in their cells, to not have the potential to become pregnant on their own. Although there are reports of women with Turner syndrome becoming pregnant because of these variety of differences in presentation. And this can be a really difficult thing, kind of speaking of psychology, this can be a difficult thing both for patients themselves and sometimes a lot more for parents or families to process and accept. We talk about how it's reasonable to sort of grieve the loss of this potential future that you imagined for your child or yourself. And we also talk about that there are many different ways to become a parent, whether it's through adoption or surrogacy or being a step parent or a pet parent, I like to say. There are many ways we build our families. And so I really encourage parents of girls with Turner syndrome to talk about all the different ways that families are formed. And at least as of now, we don't have medicine or treatments that can sort of return fertility in these cases. And we also, even if you obtain a donor egg or you did have some ovarian function that allowed for pregnancy, right now there are a lot of risks to pregnancy with the heart in Turner syndrome, even girls who have a really healthy looking heart before pregnancy, that we worry about those risks and generally don't recommend pregnancy due to the risk of it affecting your heart.
Yeah, that's really important and good to know. And of course, different families are going to have different risk tolerances. And so I'm sure that that's really something that you sit down and kind of travel that path and talk about benefits and risks and, what's important to one family may not be as important to another family. And that's where AI in medicine is not as helpful as we are humans and can connect with people on a human level and try to help them walk through risks and benefits in a very organic way. I don't know, maybe AI will get good enough to do that someday. But fortunately, right now, we still need humans in medicine to help families come up with decisions and just supporting them along the way and answering their questions and making sure they have good information on both sides of the equation.
Exactly.
Yeah. And then in terms of hot topics related to Turner syndrome research, we hear, so this is an illness that affects the chromosomes, and we hear more and more and more about genomic medicine and diseases that once were thought there's nothing we can do about this, that we can actually change DNA. Is there, I know you said right now there's no way to put a normal X chromosome in there. Will there ever be a way, do you think? Or is that just something that's, since we can treat it so well with, with hormone therapy, what do you think, Jennifer?
I think never say never. I think we don't know what the future holds. I don't think that's a possibility right now. But like you said, there were lots of disorders that we thought we couldn't treat for a very long time. But I think the important thing for right now is that we do have really good treatments and ways to support girls and their families so that, as Chelsea said, they can lead full, happy, healthy, productive lives. Like I tell my families, these girls still have to go to school. They still have to do their homework. They still get to do everything that any other girl gets to do. So I think that's important to know as well, that these kids can still be kids.
Yeah, absolutely. So we aren't to the point where we can drop one of the parents' X chromosomes into the child yet. What are some of the hot topics in research, Chelsea, that maybe we are looking at and can do?
We are looking at different ways we may be able to help the future fertility concern. So there is a procedure called ovarian tissue cryopreservation that was developed for women undergoing cancer therapy. So we are talking about women with two X chromosomes who have, we assume, to be typical ovaries, that we actually remove that tissue and freeze it in strips, instead of undergoing an IVF process where you just extract eggs from the ovary. You actually take the whole ovary out surgically and freeze it. So the National Institutes of Health, or NIH, is doing this for young girls with Turner syndrome to see if that gives them the potential to have that reimplanted tissue result in pregnancy when they're older, and that's something that they're wanting in their life. We don't know whether this will work. In the study so far, outside of Turner syndrome, we've seen over 100 live births. So we do know that the process works for more typical ovaries, but we know less about girls that have the procedure done before puberty, so before the age of 10 to 12, how successful that is. And then we don't know about it in Turner syndrome yet, which is why we don't offer it yet at Nationwide Children's. We do that procedure in other circumstances, but we want to see, and I'm really excited and hopeful that maybe this could be something helpful in Turner syndrome that we could do in the future.
When you obtain the sample and then freeze it, what age is that done?
So it would be generally on the earlier age. If girls do go through puberty spontaneously with Turner syndrome, it would be ideally done before their periods stop or they have signs either in their system or irregular periods, but could be done even at a very young age, let's say 4 years old or...
Yeah. So again, this is not something that's routinely being done. It's still being investigated at this point. But something, if you do have a kiddo with Turner syndrome, or if you remember hearing this podcast in the past, at some point in the future, certainly something to ask about. And because, again, these things progress and change and advance, and we can expect that most likely over probably the next, 5 to 10 years, maybe something like that. Again, I'm just pulling those numbers, but it seems like that would be reasonable to think.
Yeah, I I hope so. I think the hard part is saying, okay, if we take out a 5-year-old's ovary, she may not want to use that ovary for 20 years or 30 years. And so that does make the research slow in that sense, because it is reimplanting the same tissue into the same person. And so we really have that lag time of a young girl becoming a woman, being ready in her life to have a pregnancy. We're going to have a longer time frame than we would like in terms of knowing the results from research.
Yeah, absolutely. And can't speed that up, unfortunately. So let's talk, Jennifer, about Turner syndrome at Nationwide Children's Hospital. Like so many things at our hospital, I am sure there's a multidisciplinary effort here. And here we're doing that now. We have an endocrinologist and an adolescent gynecologist collaborating on the treatment of Turner syndrome. But I'm sure there are lots of other folks involved with the treatment too, right, Jennifer?
Yes. And we are very excited here at Nationwide to announce that we now do have an official multidisciplinary Turner syndrome clinic. So in addition to Chelsea and myself, we also have genetics involvement, nephrology, psychology, audiology, social work, and specialty pharmacy. So a really wide, diverse group of providers to help care for these girls all in one place. And really, like you mentioned, provide individual care, shared decision-making with the families, and really provide comprehensive care for these girls, making sure that we're addressing all of the different conditions that can go with Turner syndrome.
Yeah, very important. Cardiology, or is that more you guys would refer cardiology outside of the clinic if they were needed?
Yes. So our hope is to have cardiology on site with us soon. At the moment, we're referring to cardiology, but eventually our hope is to have everyone housed together so that parents and girls can have one very long appointment with us, but very efficient appointment to see all of their subspecialists at once.
Yeah, one trip in is better than 3 trips in a in a couple month period.
Yes,
for sure.
We provide snacks and coloring and some toys, so make it fun for the girls.
Absolutely. And how would folks get in touch with this new clinic?
Yeah, so I would say talking to their pediatrician and having their pediatrician send a referral into our clinic would be great. We can also be reached directly by calling our endocrinology division at Nationwide Children's Hospital, and they can put you in touch with me.
And we'll put a link to endocrinology at Nationwide Children's Hospital so folks can find that contact information easily. Tell us a little bit more, Jennifer, about endocrinology. You guys treat not only Turner syndrome, but really a wide range of issues. Endocrinology I find fascinating. And I think that along with rheumatology, really when there's issue going on and you're not quite sure what it is, you guys are like the Dr. House of pediatric medicine, you and the rheum folks.
Well, thank you. We certainly find endocrinology fascinating ourselves, but we treat a wide variety of conditions, like you said. One of the most common chronic conditions that we treat is diabetes. So more often than not in children, it's type 1 diabetes, but we're also seeing a lot of teenagers, adolescents with type 2 diabetes. In addition to Turner syndrome, we see a lot of other boys and girls with short stature. So we see a lot of children for concerns about growth, concerns about puberty, concerns about thyroid function, concerns about the pituitary gland, which is, if you think back to med school, that little pea-sized gland in the brain that is kind of the boss of all of the hormones in the body. So we think about it a lot in endocrinology, but all to say is we see a wide variety of conditions in children.
Yes. And Chelsea, tell us about pediatric and adolescent gynecology at Nationwide Children's. I think, a lot of parents would be surprised that there are gynecologists for kids, but it's an important field, really.
Yeah, so we all trained in obstetrics and gynecology originally. So, kind of the classic delivering babies, doing surgery for gynecologic cancers, and a wide variety of things, and then chose to specialize in pediatrics and taking care of young patients. So, we have 4 surgeons and 2 nurse practitioners in our department. So, if you think about a city the size of Columbus, that's quite a lot of pediatrics focused gynecologists. And we specialize in the medical and surgical treatment of different gynecology conditions like differences in the development of the reproductive tract. Like we mentioned, could be a reason for not getting your period, ovarian cysts, different dermatologic or skin conditions of the vulva, and taking care of adolescents who have irregular periods or heavy periods or painful periods, conditions like endometriosis. And we also really love participating in multidisciplinary care, such as the Turner Syndrome Clinic and with our endocrine colleagues and many other different conditions that involve the gynecology organs we're involved with.
Yes, absolutely. And we will put a link to pediatric and adolescent gynecology at Nationwide Children's Hospital also in the show notes. Another resource that I wanted to make folks aware of is the Turner Syndrome Society of the United States. And I know they have a lot of educational resources, both for the general public, for impacted families, for pediatric providers, also support groups, really just lots of great content there. And I'll put a link to that in the show notes as well. And then I had also mentioned the Transitioning Pediatric Patients to Adult Healthcare episode of PediaCast CME. We'll have a link to that. And we just have a general Turner syndrome information from Nationwide Children's Hospital that we'll also provide links to for all of you. And so once again, I just want to thank Dr. Jennifer Ladd with Pediatric Endocrinology and Dr. Chelsea Kebodeaux with Pediatric and Adolescent Gynecology. Thank you both so much for stopping by today.
Thanks so much for having us. This was really fun.
Thanks for having us.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast a part of it. Really do appreciate that. Also, thanks to our guests this week. Again, Dr. Jennifer Ladd with Pediatric Endocrinology and Dr. Chelsea Kebodeaux with Pediatric and Adolescent Gynecology. Don't forget, you can find PediaCast wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCast.org. You will find our entire archive of past programs there, along with our show notes, terms of use agreement, and that handy contact page if you would like to suggest a future topic for the show. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show, and we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, and LinkedIn. Simply search for PediaCast. Also, don't forget about our sibling podcast, PediaCast CME. That stands for Continuing Medical Education. It's similar to this program. We do turn the science up a couple notches and offer free continuing medical education credit for those who listen. And that includes, of course, doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by all of those professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of the episode matches your scope of practice. Shows and details are available at the landing site for that program, PediaCastCME.org. You can also listen wherever podcasts are found. Simply search for PediaCast CME. And by the way, you may have noticed that at the beginning of this podcast, I was this morning before we recorded, I was prepping next week's episode, which is actually going to be one of those CME podcasts. And I had in my brain that this was a CME podcast, and it's not. And so That's the reason why at the beginning I was nowhere close to using plain language. And so I want to apologize for that. But I think, as I realized it, I did try to bring the conversation back around to, something that could hopefully be understandable by the general public. So anyway, I apologize for that. These are the things that happen in my head. Anyway, I want to thank all of you for joining us again. Thanks for stopping by. And until next time, this is Dr. Mike saying stay safe, stay healthy, and stay involved with your kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast.